thank you for coming, and it's our pleasure to host you today. And we have a wonderful speaker today, Dr. Sigbjørn Berentsen from Department of Research and Innovation from Haugesund Hospital, Norway. And he has been leading expert in the field of hemolytic anemias, especially cold agglutinin worm, as well as the PNH. So we will start with our clinical case today. This is a 54-year-old female patient referred to our center with a preterm DAT negative autoimmune hemolytic anemia. LDH was over 1.3 upper normal limit with retic count of 125 and indirect bilirubin of 2.7 milligram per deciliter. She was diagnosed based on her response to steroid with autoimmune hemolytic anemia, and she was also worked up for other hemolytic conditions. She initially presented with the hemoglobin of 7, and then her hemoglobin normalized with the first course of oral prednisone, where she was on 2 weeks, and she relapsed after the rapid prednisone tapering, where her prednisone was discontinued within the 3 months. So the first question I have to Dr. Berentsen is, how common do we see DAT negative warm autoimmune hemolytic anemia?
Well, thank you. As you showed us, this lady has hemolytic anemia with rather marked elevation of bilirubin, but only a slight elevation of LDH, quite consistent with extravascular hemolysis. And I agree with the diagnosis of that negative wAIHA based on exclusion diagnosis above all, and the response to steroids. And to answer the question, that is negative in 3 to 10% of cases of autoimmune hemolytic anemia, depending on methods, of course. It's mostly a diagnosis of exclusion, and it can, to a reasonable degree, not invariably, be confirmed by a response to corticosteroids, as you did. To substantiate the diagnosis, more sensitive methods for that or RBC flow cytometry can be helpful, but in particular regarding flow cytometry, these methods are associated with low specificity, and the results must be interpreted with caution and must be viewed in a clinical context.
Okay, got it. So again, this patient had the prednisone tapered within the 3 months. And what is the recommended protocol for tapering prednisone in warm autoimmune hemolytic anemia patients?
I cannot remember to have seen any formal consensus on the tapering, and there are no studies with head-to-head comparison of tapering regimens. In one study of patients who tapered quickly, relapse was found to be more common than often found in the literature. In this study, steroids were tapered to less than 10 milligrams in less than 2 months and stopped in less than 6 months. So I think your patients had a definitely rapid tapering. My approach would be to reduce prednisone or prednisolone to 20 to 30 milligram over a few weeks, and then by 5 milligram every month. Usually, this will result in discontinuation after about 6 months in patients who do respond. And anyway, and that's important, only 30 to 40% will remain in remission after 1 year.
So
even if you taper very slowly.
Okay, so that's good to know. So let's say this patient, tapered properly and then relapsed. What is going to be the second-line treatment option for this particular properly tapered patient?
Well, in the second line and not listed on this slide, if there is a relapse after tapering or a failure of response, one should consider a second diagnostic workup, and I think we will come back to that. Because if it is a secondary autoimmune hemolytic anemia, treatment for the underlying or associated disease should be considered at this point. But as for treatment for the wAIHA itself, rituximab is today the second-line standard therapy. And 3 dose schedules have been investigated. First, the standard lymphoma dose of 375 milligrams per square meter for weekly for 4 weeks. Then 1,000 milligram fixed dose day 1 and 15. And as an alternative, there is also a fixed low dose regimen, 100 milligram weekly for 4 weeks. That fixed low dose has been found to yield about the same response rate in primary wAIHA, but not in cold agglutinin disease, which we are not discussing today. The response rate to rituximab appears to be around 70 to 80 or 75 to 80%. The median time to response is about 3 to 6 weeks, depending on which study you read. And the range appears to be 2 to 16 months. So you should allow at least 4 months to look for a response. And 30% of responders are reported to relapse within 3 years.
Okay. This is interesting. So when you say it may take up to 16 weeks to respond, so that means 4 months after the patient being exposed to rituximab. Is that your practice as well? Sometimes can lag the response behind?
Yes, it can, because it depends on how active, it depends on the biological activity of the autoantibody. And in some patients, you have to eradicate most of the antibody producing cells to see a response.
Okay, got it. And when you apply the second line, let's say the patient responded for a year and relapsed after a year, do you repeat the rituximab because the patient responded the first time, or do you consider other B-directed therapies?
If there is a relapse very early, for example, less than 1 year, I will consider third-line therapies. If there is a relapse, let's say after 2 years or more, I will repeat rituximab.
Okay.
I think there was also a question from the audience just now about workup for lymphoma, what to do to diagnose any lymphoma in these patients, and I think we will come back to that.
Yeah. Okay. So does really age or presence of underlying autoimmune disease influence the selection of rituximab dosing that you outlined?
I haven't seen that question very much in the literature, and my thoughts will be that age has hardly any influence, but other autoimmune or other underlying diseases may have. For example, if rituximab can be assumed to beneficially affect the underlying disorder, I would not use the fixed low dose.
When you say fixed dose, 100 milligram per meter
100
square
milligrams per week,
per
fixed
week,
dose,
right?
yes,
Yeah.
4 times.
Yeah. Okay. So, what should be the secondary workup if we are thinking that patient may have some underlying problem that is provoking the wAIHA?
Yes, as I said, secondary workup should be considered in patients who fail to respond to steroids or who has an early relapse after steroid therapy. And such a diagnostic re-evaluation should focus on any overlooked causes of secondary wAIHA. It might be CLL or autoimmune diseases or B-cell lymphomas and so on, or any coexistent non-immune causes of hemolysis. We do see rare patients who may have, for example, a hereditary hemolytic anemia in addition, or PNH. So relevant examinations, and the first three may appear to be a matter of course, but they are extremely important. After all, we are clinicians, and most of our tests should be based on clinical evaluation. So a careful review of the medical history is very important, and also a careful review of medications to consider or exclude drug-induced hemolytic anemia, and of course a thorough physical repeated examination. And then serologic markers of autoimmune diseases, relevant viral or other infection-related serologic tests, serum protein electrophoresis, and Ig class quantification, flow cytometry in peripheral blood and bone marrow, and it should be considered to include a PNH flow cytometry. And as an answer to that question about lymphoma, at this stage, a bone marrow biopsy should be taken in all patients, and whole body CT should be considered.
Okay. So how often do we see underlying lymphoproliferative disorders when it comes to wAIHA, secondary wAIHAs?
Rather often, but the most frequent underlying lymphoproliferative disease is CLL. So other non-Hodgkin's lymphomas are more infrequent, but I can't give you the exact frequency, but we do see them.
Okay. So let's say the patient is opted in for possible rituximab or splenectomy. So most of the time we do use the rituximab over the splenectomy for so many reasons. So can you allude on why are we not using splenectomy more often than the rituximab if it's a more curative option?
Yes, I can try. To the first question, the response rates, at least considering the immediate response, are probably comparable, 70 to 80% response rates to both rituximab and splenectomy. However, the rate of long-standing responses is less documented with splenectomy. And still, in most cases, and according to my thoughts and according to international consensus, rituximab should be preferred over splenectomy in the second line. And that's mainly because of the drawbacks of splenectomy. There is a risk of fulminant infection, at least, and in particular during the first year. And patients with autoimmune hemolytic anemia have an increased risk of thrombosis, and splenectomy increases that risk further. And third, splenectomy, as all of us know, is an irreversible procedure. However, splenectomy should not be forgotten as an often effective option in the third line.
Okay. That's good to know the risk of the infection within the first year. Okay, so let's say this patient is treated with rituximab, relapse within the year or within the 9 months of being exposed to rituximab. Now you're considering the splenectomy, and what will be the complication of splenectomy, and who we should be sparing from splenectomy option?
Well, I think we have already discussed the complications, and there are some types of autoimmune hemolytic anemia in which splenectomy is discouraged. First, if the red cell destruction does not occur mainly in the spleen, which is the case in cold agglutinin disease and secondary cold agglutinin syndrome, where the hemolysis primarily occurs in the liver, and in the very rare PCH, where the hemolysis is intravascular. And then this patient had a DAT-negative autoimmune hemolytic anemia. And in mixed autoimmune hemolytic anemia and the DAT-negative cases, we usually discourage splenectomy because there are no studies particularly looking at these subgroups. So there is really no evidence in the literature for effect, and clinical experience is generally negative. I have been talking with my friends and colleagues in Milan, Italy, which is a very large center for treatment of wAIHA, and they don't use a splenectomy in these two subgroups because of negative clinical experience.
Okay. So can we, when we say these are the condition that we should be avoiding, so is that because DAT negative or mixed AHAs, do they have less response to conventional treatment for wAIHAs?
I don't think you can say that about the DAT-negative cases, but the mixed autoimmune hemolytic anemias is a difficult group to treat. They may have poor response to steroids, and most experts think that they should be initially treated by a combination of high-dose steroids and rituximab upfront. And if they have clear features of cold agglutinin component, which may be the cause, then one should consider treatment like cold agglutinin disease.
Okay. So what is
And
the
I could add to the last slide, if you can go back for a moment. In addition to the groups in which splenectomy is discouraged because poor documentation or lack of effect, there are also some contraindications. For example, we are reluctant to doing splenectomy in patients more than 60 years because of the risk of complications, and also in SLE, splenectomy is discouraged. wAIHA may in some cases be secondary to SLE, and we think those patients should not be splenectomized.
Okay, yeah, good to know this part too. So do you prefer to do, open splenectomy or laparoscopic? And what is your prophylactic anticoagulation recommendation for post-splenectomy?
Well, laparoscopic splenectomy in my head should be preferred, and there are some literature support for that opinion. And as for prophylactic anticoagulation, there are no evidence-based recommendations, but as I mentioned, patients with autoimmune hemolytic anemia has an increased risk of thrombosis because of the hematologic disease. And when you increase that risk by surgery and then by removing the spleen, you should consider an extended postoperative anticoagulation. And if the patient continues to have wAIHA, if there is no response to splenectomy or poor response to splenectomy, you should consider anticoagulation, for example, with a DOAC, indefinitely. But that's not an evidence-based opinion.
Okay. So what is your recommendation for vaccination for people who is going to splenectomized? Is that the regular encapsulated bacterial vaccination or what else?
Yes, vaccination against encapsulated bacteria is, in my opinion, mandatory, and according to most consensus papers too, mandatory. I think we should refer to national guidelines for splenectomy patients, and I think in the US you have the very good CDC guidelines, and according to them, patients should be vaccinated against encapsulated bacteria. As for prophylactic antibiotics, you may know that in most of Europe, and in particular in my part of Europe, we try to avoid unnecessary prophylactic use of antibiotics because there are resistance problems, and we have been rather successful. So in our countries, these encapsulated bacteria are usually sensitive to penicillin. So, but of course, prophylaxis is indicated in emergency splenectomy if performed before vaccines can be expected to having taken effect. Patients are also advised to take antibiotics. In Norway, still penicillin. I think in the US, probably ciprofloxacin at once in the case of high fever, and then seek urgent medical attendance. So we provide the patients with a small amount of antibiotics and advise them to take it in those cases.
Okay, very similar recommendation here in the state as well. Okay, so again, I think I wrote this question, but this is something that maybe if you have anything to add, which patient should not be going to splenectomy? And we went over this, including the age.
Yes, I think we went over this, and as I said, in addition, there are some specific contraindication. We regard old age as a contraindication, and also some underlying disorders, for example, SLE.
Okay, got it. So I'm changing gear a little bit, and again, this patient relapsed after the laparoscopic splenectomy, and now you are considering the third line agents, and those are the all conventional, anecdotal drugs that has been tried for warm autoimmune hemolytic anemia patients. So, how's your feeling about each one of them, and what is the response rate and time for these agents?
I think that was the most difficult of all of your questions. And as you said, there are much anecdotal reports. The evidence for most of these treatments is weak, and I think almost without exception, the exact response rates are unknown. That's because most of the evidence is pooled case reports or very small retrospective studies with poorly defined inclusion criteria, no or heterogeneous response definitions, and a high risk of publication bias. There may be some exceptions. For example, my very good colleagues Bruno Fatizzo from Milan published a systematic study on cyclosporin. But even in that studies, the number of patients with autoimmune hemolytic anemia was small. So I think all of these agents may have effect, but we actually don't know the response rates, and it's very difficult to recommend a specific approach based on the studies. I happen to know that in the US, my very good colleague Dave Kutter in Boston prefers mycophenolate mofetil, but I think you can argue for and against all opinions.
Yeah. I mean, the mycophenolate is the easiest and the least side effects profile among the cyclosporin, cytoxin, azathioprine, and you can add tacrolimus or the sirolimus here as well. But again, I think it's the kind of physician choice when it comes to third line, if you want to spare or if you want to wean down as low as the prednisone. But it's difficult call when it comes to third lines.
Yes, I agree. In some patients, also long-term low-dose prednisolone may be an alternative.
Yeah, that's always something to keep in mind, the lowest possible dose.
Yes.
So, I mean, again, we are practicing hematologies and we want to know what is coming into the horizon and which one is showing more promise than the others, because there has been several publications in the recent 2-3 years, and there is a big efforts, the complement inhibitors, the FcRn receptor inhibitors, as well as the newly evolving BTKs and BAF receptor inhibitors. Can you little bit allude on each one of these agents and see which one do you think is gonna be the one that will be promising?
Yes, I can try. To try to discuss these newer agents, I have listed them here. And first, there are some of the newer approaches that is fairly well evidence-based today. And for the first of these bortezomib-based combinations, there is one small but good retrospective study and one small but good prospective study. And I think bortezomib-based combinations are usually fairly well tolerated. They have a good chance of inducing remission, and bortezomib-based combinations may be used as a last resort. For example, bortezomib plus dexamethasone plus rituximab, often with success. So in the third or last line, that combination should be considered. Erythropoietin or EPO analogs is another option. There are two fairly good retrospective studies. Even the first of those was relatively small, and also a prospective studies. And so you can see EPO as a parallel to the TPO agonists in ITP. And especially in patients with an inadequate endogenous EPO response or inadequate retic response, will have a reasonable chance to profit from being treated with EPO. So that's definitely an option in the third line. And also we have the studies of fostamatinib, the splenic tyrosine kinase inhibitor. There was a promising phase 2 study, mainly from the USA. Unfortunately, a phase 3 study was apparently more disappointing, but in that study, there was a high frequency of protocol violations, mainly use of protocol prohibited rescue therapies, especially in Eastern European countries, not in Western Europe and not in the US. So when they excluded the countries with most protocol violations, the beneficial effect was easier to demonstrate. So I think fostamatinib is an option in the third line. As for the more investigational therapies, it is, of course, impossible to say anything about response rates because there are no results yet. Inhibitors of the neonatal Fc receptor, nipocalimab and others, are very promising. I will come briefly back to that on the next slide. There is also a novel SYK inhibitor, sovleplenib. The results of a phase 2 study are promising, but we are awaiting the results of a phase 3 study, which is ongoing. And then we have the cytokine or BAFF/APRIL inhibitors, povetacicept, which inhibits both of those cytokines, and ianalumab, which is BAFF receptor inhibitors. I think we will have to see the results before we can conclude. The complement C3 inhibitor, pegcetacoplan, I think it's promising based on phase 2 basket study. It is promising for patients with complement activation, that is, patients with DAT positive for C3d. But unfortunately, further studies in autoimmune hemolytic anemia, including CAD, have been stopped by the company, so we don't have the results. But I think pegcetacoplan could be tried in patients with resistant warm autoimmune hemolytic anemia, which is DAT positive for C3d. And then we have the novel B-cell directed approaches, rilzabrutinib and parsaclisib. I think phase 2 studies with those compounds have been completed, but we haven't yet seen the results. And then daratumumab may be effective in some patients with wAIHA. So for all these options in the second column, we can't say anything about the response rates or the safety, but I think the main conclusion from this slide will be that patients with refractory autoimmune hemolytic anemia should be considered for clinical trials if available, and that's very important. And if you can show the next slide, I will just comment on the prospects of inhibiting the neonatal Fc receptor. That receptor promotes recycling of IgG, cellular recycling of IgG. So if we inhibit the FcR receptor, the neonatal FcR receptor, we can reduce concentration of autoantibodies, IgG autoantibodies, by 80 to 90% without inhibiting the production, without reducing IgA or IgM, and without reducing the effect of vaccines. So that's very interesting prospects. But as I said, the study has not been completed and published.
Yeah, thank you for your insights for the evolving landscape of this warm autoimmune hemolytic anemia patient disease. So, I mean, I think this is the last slide. We wanted to kind of bring to our attention what mistakes that we should be not doing when it comes to autoimmune hemolytic anemia. Do you want to go over them, Dr. Berentsen?
Yes, I will. Of course, I have no evidence to tell you anything about what is the most common mistakes, but in my opinion and in my experience, I have listed some common mistakes. First, a common mistake, at least worldwide, is not performing a monospecific DAT. You have to perform a monospecific DAT to be able to classify the autoimmune hemolytic anemia, and you have to classify the autoimmune hemolytic anemia as well as you can in order to determine the best therapy for the patients. Another mistake is when you have performed the monospecific DAT, some colleagues interpret a DAT which is negative for IgG and positive for C3d only as pathognomonic for cold agglutinin disease. It is often cold agglutinin disease when you see that pattern, but it may also be a secondary cold agglutinin syndrome. It may be an IgM, and it may be an IgM-mediated warm autoimmune hemolytic anemia, which is uncommon but can be very aggressive, can be a severe disease, and it's is important to recognize. Then we have.
Is that the way that we need to look at the slide, right? If there's agglutination, if there is
Yes, you have to look at the slide,
syndrome.
and also you have to do a cold agglutinin assessment. We do a cold agglutinin titer directly if we see that pattern. And then there is sometimes an overuse of corticosteroids. And fourth, of course, maybe not very relevant for our topic today, which was wAIHA, but for autoimmune hemolytic anemia in general, the use of corticosteroids is a problem when it is not indicated, and that's the case most importantly for cold agglutinin disease. And then we have not discussed transfusions today, and I think our time is up, so we can't. But there is both under and overuse of transfusions. Some colleagues transfuse wAIHA patients who don't have any severe symptoms of anemia and have a hemoglobin, for example, of 7 and 8 and 9 and stable disease. Those patients shouldn't be transfused. But on the other hand, underuse of transfusion can be dangerous if a patient with autoimmune hemolytic anemia is very severely anemic, and especially if there are organ symptoms of anemia, or if the hemoglobin is declining very rapidly, the patients should definitely be transfused. Of course, observing the precautions necessary for transfusions in this disease.
Great. And do you think we should also add the under recognition of iron overload among these hemolytic anemia patients?
Maybe, I'm not quite sure, because we see an iron overload, for example, in patients with cold agglutinin disease, in some cases, not in all cases, but in some cases. But we very rarely see clinical manifestations of iron overload. So maybe not the most important point, but perhaps.
Okay, great. I think we have at least 5-10 minutes to go over if there's anyone has any questions. I think we covered most of the important aspects of warm autoimmune hemolytic anemia, including how to deal with the DAT negative, what dose of rituximab we should be choosing for what agent, what patient populations, who we should be considering splenectomy, and what we should be doing if we are thinking about the third line, and even the what is coming on the horizon with the newer treatment agents. So does anyone has any question in the audience? Okay, great. I think we can pause here, Dr. Berentsen. I mean, I think this has been a wonderful session, and thank you for your time and for your insight. And we are looking forward to hear your insights in the future sessions. Thank you.
Oh, thank you, and the pleasure is on my side. Thank you for inviting me.